there. We're gonna be doing pelvic masses today. So pelvic masses occur relatively commonly in women of all ages. Um, the approach to the management of pelvic masses is influenced by the patient's presentation, appearance of the mass, the patient's age. So basically, it's patient's clinical factors. So there are various causes of pelvic mass, which range from physiological phenomena such as functional ovarian cysts to malignancies and non-gynecological conditions. So I'm going to give you differentials for a pelvic mass. We have pregnancy-related causes, we have gynecological causes, and we have non-gynecological causes. Under pregnancy-related causes, it's an enlarged uterus of pregnancy, can be the corpus luteum of pregnancy, or it can be an ectopic pregnancy. Under gynecological conditions, we have those that occur within the uterine cavity, such as adenomyosis, fibromyomata, and those that occur in the fallopian tubes. We may have inflammatory masses, hydrosalpinx, and those that occur in the ovarian system. We may have benign cysts. They may be functional or non-functional. We may have malignancies of the ovaries, and we may also have endometriosis. Under non-gynecological causes, it may be appendiceal mass, it may be a pelvic kidney, it may be lymphadenopathy other than secondary to gynecological malignancy, or it may be a diverticular disease. So the clinical presentation of a patient with a pelvic mass, she may be completely asymptomatic, and it might be an incidental finding on examination, abdominal or gynecological examination. And then in women who have symptoms, this may be limited to the pelvis, such as a palpable mass arising from the pelvis, or they may have a pelvic pain, or they may have pelvic swelling, or they may have discomfort in the pelvic area. General clinical features that should be noted in these patients include jaundice, anemia, and edema. This patient's condition should be assessed, and systemic examination should include an assessment of lymph nodes and the chest and abdomen and pelvis should be thoroughly examined. In young patients who are not sexually active and who you cannot do a full gynecological exam, an abdominal ultrasound can prove extremely valuable. Remember, in these patients, you want to do a bimanual exam. So when they say young patients, they're actually meaning virgin patients. So special investigations you will do for patients with pelvic masses. You will do your normal your routine bloods. You must take hemoglobin. It might be the what HB, or you may take it from the labs. You must do urinalysis to rule out infections. You must do a pelvic ultrasound. You do a serum beta HCG in all premenopausal patients with pelvic masses, because every woman you see is pregnant until proven otherwise. You must do cervical cytology, that may be in the form of pap smears. Further tests, you can do a serum CA-125. You must check for the HIV status. You must check for the ESR. You must check for the white cell counts, that's in the full blood count. You must check for CRP. And the cornerstone of assessment of a patient with a pelvic mass is a combination of the clinical examination, a thorough history, and transvaginal ultrasound. So there are criteria on ultrasound that are actually associated with a benign ovarian cyst. That is unilocularity, there will be one cyst. Clear contents, either those should be echo-free contents. Thin cyst walls, smooth cyst walls with no papillary growth on the cyst wall, and the size is usually less than 8 centimeters in diameter. and it's usually unilateral, and there is no ascitic fluid present. Now, features of malignancy on ultrasound for a patient with a pelvic mass: it will be a solid or cystic and mass. There will be multilocular cysts. There will be thick cyst walls. Papillary growths will be there on the outer surfaces. It may be bilateral, and there is usually ascitic fluid present. In addition, ultrasound is used in assessment of the uterus and the bladder. So I'll give you a few examples of common scenarios that include a pelvic mass. First example, it's a pelvic mass with pain and bleeding, positive beta HCG of more than 1,500 international units per liter with an empty uterus on ultrasound. Then your possible differential will be an ectopic pregnancy. Second scenario, it's a pelvic mass with pain and bleeding, a positive beta HCG, and there's a fetal sac in the uterus. Then you can say, okay, threatened miscarriage. The third scenario is a solid pelvic mass with pain, excessive bleeding, infertility, and irregularly enlarged uterus. I'm sorry. That's a fibroid uterus. And then a pelvic mass with pain and fever, high ESR and white cell count. Then you can think towards infectious causes of the mass. So in cases where you suspect malignancy of the ovary, you should take bloods for beta HCG and CA125 levels in all patients. If the patient is young, teenagers and those in the early 20s, and a germ cell tumor is suspected, then you should do alpha-fetoprotein and LDH levels. And then all cases of suspected malignancy should have a hematological and biochemical assessment, as well as a chest x-ray. This is to rule out the chance that this could be a secondary manifestation or a metastatic lesion. So abdominal ultrasound may provide useful information on the status of the liver and the kidneys and the presence of ascites. If the history indicates possible gastrointestinal involvement, a barium enema or colonoscopy must be performed. So coming to management, this management is based on cost. So for acute conditions, there are relative managements. If it's an ectopic, you're going to treat it respectively, either medically or surgically. Management of miscarriages or pelvic abscesses. If it's a fibroid uterus, it varies depending on the size of the fibroid uterus, the symptoms, fertility aspiration, and the age of the patient, the desire of the patient for future fertility. So not all fibroids will actually require a surgical resection, and some or most patients will require a hysterectomy. If it's an ovarian cyst, you must do a beta HCG measurement, and then you can offer the patient progesterone. If the beta HCG is negative, you offer them progesterone for 5 to 10 days, and then or a course of the combined oral contraceptive pills to block gonadotropin stimulation of the ovary and cause luteinization and resolution of the cyst. So those persistent or complicated cysts should be explored surgically, and then you can do an ovarian cystectomy in young patients. In postmenopausal patients, cystic lesions should usually be resected. So in cases of possible malignancy, you progress to surgery, preferably an open surgery. And then patients with ovarian tumors which are clinically suspicious of malignancy in all age groups must be prepared for a laparotomy. And the mainstay of surgery is a total abdominal hysterectomy, bilateral salpingo-oophorectomy, infracolic resection of the visible tumor, and removal of the ascitic fluid for cytological assessment. And that is the end of our topic on pelvic masses. Do add questions and comments. Thank you. Bye.